Evet, hoş geldiniz.
Welcome everyone. Let's start our session. Today's topic will be delivered by Professor Dr. Wim Dan Brink. I'm not sure which should be the language that I should be speaking. Professor Wim van den Brink dedicated his profession to understand the mechanisms, the impacts of addiction actually, and he is a pioneer, an important author in this field. And today he will be delivering a speech in regard to addiction. It is not just substance addiction, but also internet, technology, digital addiction will be a part of his speech. As far as I know, the floor is yours, sir.
Thank you very much. I guess this was a nice introduction, but you never know.
It was.
Thanks for inviting me here in this beautiful country and this beautiful place. And this morning I'm going to spend about an hour and a half with you talking about ADHD and addictive behaviors. And so the first part of the talk will basically about ADHD and substance use disorder, but there is other forms of addiction, behavioral addiction. So if time allows, I will say a few words also on ADHD and its relationship with gambling, pathological gambling, and gaming. We were just discussing this whole situation with the lockdown and the kids being at home and playing games all the time, and we're just exchanging ideas whether this is good coping or potential pathology. I think probably it's both. And being in a lockdown and having good games and being in contact also with other people in the world is quite a good solution, I think, for most kids. And the question is, there are probably kids that might run a risk there. I think, which will be clear from the talk later on, that kids with ADHD probably are in a specific risk for that. But altogether, I guess that many of this gaming that the kids have been doing in these lockdown periods will subside again, and they will be again, like most kids who use alcohol or drugs, maybe even excessively during some years of their life, become responsible parents and active society members. It's a subgroup, and I think ADHD, kids with ADHD run a specific risk, which doesn't mean that this is uncontrollable, and I'm going to show some data that we might actually do something there. So this is in terms of the prevention. I'm also, whenever I'm standing here, I think, are these my slides? They look so good on this big screen. So I always have to make disclosures. I work with a lot of pharmaceutical companies. Sometimes people say I'm polymorph perverse. I do it in every other way with all kinds of organizations. And I'm still proud that in the field of addiction, pharma industry is still interested, because they lost their interest actually in schizophrenia and in affective disorders. They might gain that interest back with the appearance of the psychedelics, but in my field they're still interested in doing some research, so I'm happy that I can gain from that. So what I try to do in this hour and a half, I will say a few words on ADHD and substance use disorder, something about the epidemiology, the genetics and the neurobiology and the overlap between these disorders, and then move to what that means for the prevention of the development of substance use disorders in children with ADHD. Because just to start off, if a child comes to treatment, the probability that he develops, or her, the probability that he develops an addiction is about 40–50%, which is dramatic. And so will develop the addiction, the substance use disorder. And so well chosen, because I have a tendency to think that ADHD and addictive disorders are just one disorder. The one is expressed from childhood on, and what comes later are addictions, and it's probably the same. Same genetic predisposition. I also, and I think it's not a surprise, that ADHD, substance use disorder, and definitely pathological gambling, they share a very similar underlying neurobiology, and this may also be true for gaming disorder. An important message, and maybe the most important one, is that early stimulant treatment, you might need much higher dosage in your treatment, which raises a lot of clinical issues, like you have a patient with ADHD and an addiction, and you start giving him high doses of stimulants, and aren't you creating a new addiction? Are you doing substitution treatment, or are you doing the treatment of the ADHD? So I think very important issues that is not only important for the psychiatrist, but definitely also for parents who have to understand what the doctor is doing, and patients who have to understand what the doctor is doing. So it's clear that we know quite a lot about ADHD and substance use disorder, but I think we need much more studies on ADHD and pathological gambling and gaming disorder. So these are the take-home messages, but first I will go on to look around what ADHD and substance use disorders have in common, and starting with the epidemiology. This is an old study of 2007 looking at the prevalence of ADHD and substance use disorder in the general population. And you see this was a multi-country study, and what the main finding of this cross-sectional community study was that the lifetime prevalence of ADHD was about 3.4%, which is a number that you all probably recognize. But if you looked in this general population sample, if you looked at, I can't say patients, people with an addiction, their lifetime prevalence of ADHD was 12.5%, which means an odds ratio, or a relative risk, of 4. So they had 4 times as often ADHD than the ones without an addiction. And an important finding was, and of course, because ADHD starts early, ADHD was first in 99% of the cases, so first ADHD and then they develop an addiction. In that study in 2007, in these different countries, ADHD was not treated in the general population sample. In the USA, it was 13%. In all the other countries, it was 0 to 3%. Now that has changed in the last 10 years, of course. There's much more treatment of ADHD. But I also show there a study in 2016, and the results are basically very similar. Odds ratio of about 4, that people with a substance use disorder are much more likely to have ADHD. This was a large meta-analysis that we performed some almost 10 years ago, looking at 29 studies with 4,000 adolescents and 600 adults. The overall prevalence of ADHD in patients coming for substance use disorder treatments was 23%. 1 in 4 or 1 in 5 of all patients coming to addiction treatment had adult ADHD. And that was both true for adolescents and for adult patients. So if you go to an addiction treatment center, be aware that about a quarter of the patients will have adult ADHD. This was one of the first prospective studies, a study from 2008, looking at the cohort of 176 children, and they were all treated with methylphenidate, and they were started that treatment relatively young, between the age of 6 and 12, and they were followed up for another 12 years. At that time, they were between, on average, they were about 23 years old. And at that time, 45% of these ADHD kids had a substance use disorder, either alcohol use disorder or a drug use disorder. So that's quite a shocking number, isn't it? If you come for treatment as a child and you get a stimulant, 12 years later, 50% has an addiction. You could also say another 50% doesn't have an addiction, so maybe we can predict the ones who have an addiction. And this is not the only study. I just mentioned one in the bottom that really found the same kind of numbers, because people don't believe you if you say half of your patients with ADHD, if you don't do anything, they might become an addict. This is, again, meta-analysis. 2 very large meta-analyses, again showing that the risk that ADHD patients develop a substance use disorder is between 2 and 3. You have to say this is a relationship that was not controlled for the presence of a conduct disorder. As you may know, ADHD and conduct disorders go together quite often, and there's a whole discussion whether this relationship between ADHD and substance use disorder maybe is mainly because of the comorbidity with the conduct disorder. And so this is really the question in the rest of my talk. I assume that ADHD has an independent causal relation with substance use disorder, but some people say, no, it's not a direct relationship. It's ADHD increases the probability that people get a conduct disorder, and the conduct disorder is the risk factor for substance use disorder. And of course, there's many more other relationships possible. And just to show you that this is an original study from 2007, and JAMA Psychiatry was still called Archives of General Psychiatry. This is probably one of the best studies done, and it shows actually if you control the effect of ADHD on addiction, that relationship seems to largely disappear. And anyway, only the attention is, if you control for attention, there's no relationship anymore, but there is definitely a direct relationship between the dimension of hyperactivity, impulsivity, causing substance use disorder. So this is one of the studies. There are a few other studies. This was a study from 2009 already, and showing in a population at the age of about 40 years, looking back and showing that what was the probability that patients developed an alcohol dependence. And if you neither had ADHD or conduct disorder, this probability of getting an alcohol use disorder was relatively small, 7%. If you only had ADHD, that risk doubled to 12%. If you only had conduct disorder, you see the risk is even much higher. And if you have both ADHD and conduct disorder, the risk becomes like 6 times as high. But again, it shows that although a little smaller, you see ADHD has an independent, is an independent risk factor for the development of, in this case, alcohol dependence. This is a study from the Netherlands showing basically the same thing. They followed patients from age 6 to age 17, and they looked at whether they developed alcohol use disorders and drug use disorders in that picture. And you see for the healthy controls, which in this case was patients, young patients, without ADHD or without conduct disorder, you see that the prevalence of developing a substance use disorder was about, what is it, 6-7%. As soon as you had ADHD, even if it was without obsessive oppositional disorder or without conduct disorder, you see this risk increases quite high, and you here have an incidence of about 15%. So you go from 3-4% to 15%, which is a large increase. And that was independent of the comorbidity with conduct disorder. Of course, it becomes higher when you have a comorbid conduct disorder. But you see this is an independent relationship. So to summarize all these numbers, I'm not going into it too long, but it's clear that if you have, in the general population, patients with an addiction in the general population have a probability that's about 3 or 4 times higher than of having ADHD than people in the general population without an addiction. But the shocking number is, of course, that about 50% of all children that comes to treatment for their ADHD will develop an addiction by the age of 25. I think that is a strong message. And the other one is that if you see patients in an addiction treatment center, be aware that anywhere between 15 and 25% will also meet criteria for adult ADHD. It's not only that they have it in childhood, but these are patients that develop adult ADHD. So what does it mean for clinical practice? I think if you see these prevalence rates, then you have to conclude that all patients with ADHD need to be screened for their alcohol and drug use and the presence of an addiction. And I here mentioned some of these screening instruments. And it also means that all patients who come to substance use treatment, they should be screened for ADHD. Because the prevalence rates are so high, you have to check on it. And of course, if you have a positive screen, then you have to do proper diagnostics using either the CADIT or the DIVA, but you have to do the screening and followed in case of a positive screen by a structured diagnostic interview. Also, I would like to mention that there is good data now that you don't have to wait with the screening for ADHD until people are completely abstinent, because you might wait for nothing. So if patients come in, start to screen, there's good data now that screening, even while they're still actively using drug, is quite useful, and that you get valid data from that. So screen as soon as you can, and of course, if you have a positive screen, do a diagnostic interview. So how do we think about this relationship between ADHD and substance use disorder? These are potentially the 5 ways that the different disorders might be related to each other. And so the first could be that people have a substance use disorder in the course of a substance use disorder. For example, if they use a lot of cocaine, they become restless, and what you see is adult ADHD. I think that relationship is not so likely, because in most cases, as I showed you with the first slide, ADHD actually precedes the development of substance use disorder. So this is not a very likely relationship. Another one could be if you have ADHD and you come into contact, for example, with stimulants, you might have a relief of your ADHD symptoms. And so some people still think that children with ADHD, they have a preferred addiction that's for cocaine or for amphetamines. That's not true. They have a higher risk for all kinds of substance use disorders. So it's not specifically for the stimulant addictions. You might think that they come into cannabis. We talked about it a little bit yesterday evening in some conversations. And they might notice that they have a lot of ADHD patients have sleeping problems. And so if you use cannabis, you solve some of your sleeping problems. So it's not enough to say to your patients, you have to stop using cannabis, because they say, but I have a sleeping problem. So I think what you have to address is sleeping problems. And so there are other solutions for that. There may be better solutions, but they have a reason to do that. So ADHD, by this kind of self-medication, could actually create substance use disorder. That's definitely a possible pathway to addiction. Another way is that maybe substance use disorder and ADHD share the same risk factors. That could be genetic risk factors, genetic predispositions, or environmental risk factors. And of course, I just mentioned a few here, but there are probably many more risk factors that are both risk factors for substance use disorder and ADHD. And the same is true for environmental factors, affective neglect, child abuse. They're known risk factors for either substance use disorder or ADHD. And so sharing this risk factor might, at the long term, also make that you share the same diagnostic outcome. Finally, there's two other ways that if you have ADHD and you have a substance use disorder, it's clear that treatment is not going so well. So this is sometimes called psychoplasty. It's probably true, but I'm not sure that this is the most important part. And finally, the same could be said by the treatment of substance use disorder. If you have ADHD, you might have much higher dropout rates, and actually you see a much more chronic course of the substance use disorder. And if you have chronic courses, they tend to go together and you get higher comorbidities. So these are kind of the theoretical models that we have. And this was a beautiful review that was written in 2014 by Molina and Pelham. And they really try to make an inventory of all the mechanisms by which ADHD is moving into a substance use disorder. I'm not going to go over all of these, but they say ADHD symptoms look like personality traits, and it's this kind of thrill-seeking behavior or sensation-seeking, a trait that we also know that's a risk factor for substance use disorder. You can say ADHD is related to ODD and CD, and maybe that's the relationship to substance use disorder. So they mention a lot of these different pathways, and of course they come up with this beautiful picture, which actually shows the development from birth, pregnancy and birth, through childhood, adolescence, and adulthood. And what it shows here is the neurobiology of substance use disorder and ADHD, and then here you have the ADHD and the neurobiology and the impulsivity that relates to all kinds of academic failures, social difficulties, conduct problems, and from there you can see that people might get into peer groups where there's a lot of drug use, and finally through this whole pathway they develop a substance use disorder. So this is the picture that he presents, and I think it's a wonderful thing. He also indicates where you could do treatment interventions. So it's a wonderful way to looking at these developments. But I will try to simplify this a little bit later, and maybe you will be quite shocked about it. And maybe that's what I like to do. So maybe there's something like some CD pathology in me still left, even at the age of 70. So this is the more complex picture then that I showed you before. ADHD, through all these mechanisms, can have a direct relation to substance use, including the ones through conduct disorder. Now, the question is, I mentioned here, you see, the genes and the environment, the shared genes and the shared environment that might cause both disorders. How is it with the genetics of ADHD and substance use disorder? This is an early family study in 2008 in my favorite journal, Psychological Medicine. It's underestimated nowadays, probably because the word psychological is in it. And so psychiatrists don't take it serious, but Psychological Medicine is a wonderful journal. This is an old-fashioned thing like family study. But still, it's interesting. What you see here is this is parental alcohol dependence, and this is the disorders that you see in the offspring. And what you would expect that if the parent is an alcoholic, that there is a higher risk that the child also will be an alcoholic. And you see it's here, it's an odds ratio of 2.1 or 2.2. But at the same time, you see that these kids also have a higher risk, actually an even higher risk to have ADHD ODD and CD, and actually all the antisocial behaviors, they're also increased in these parents with alcohol problem. Here you see the same thing for parents with drug dependence, and you see, of course, you expect that these kids have a higher risk of drug dependence, but these kids also have much higher risks of ADHD and conduct disorder. So you see there seems to be a familial factor that is transmitted that is true for both ADHD and substance use disorder. Now, familial factors doesn't mean that it's genetic. It could be genetic, but it's only familial. So you start to go to studies that do twin studies. And twin studies, this is a study from Kenneth Kendler, probably one of the greatest psychiatrists that ever lived, great person. And in the Archive of General Psychiatry in 2003, he showed the twin study, what he called the common psychiatric mental disorders. And so you see, you see here the different disorders. You see major depression, generalized anxiety, phobia, alcohol, drug dependence, antisocial behavior, and conduct disorder. You hear it well. There's no ADHD there. This is 2003. We didn't talk about ADHD in 2003. And so what you see here is the twin studies. And so in twin studies, you can make a distinction between additive genetic effects of the disorder, shared environmental factors, and unique environmental factors. Only the red ones are highly significant. And what you see is that all the addictions share the same genetic factors with antisocial behavior and conduct disorder. So there's one shared genetic factor of these, and we call it externalizing genetic factors. If people would have, if they would have included ADHD, my suggestion or my assumption is that ADHD would actually rank in the same level. But they didn't do it. So some years ago, it's already 7 years ago, we decided that we do a family study, a twin study looking at the overlap between ADHD and alcohol dependence. And so what we found in this twin study was that the heritability of ADHD in this population was about 38%. You think it's low. Actually, it's not. If you look at the heritability of ADHD in childhood, it's about 60, 70, or 80%. But with time, you see that other factors come in. And if you look at adult ADHD, the heritability is a little lower. Here's the heritability of alcohol dependence, and you see it's about 50%. That's what you would expect. And then we looked at the phenotypic overlaps, which is just meaning the comorbidity of the two disorders. And the correlation was about 0.30. And we tried to explain this comorbidity, this 0.30. And then we found that actually this comorbidity of ADHD and alcohol dependence was for 91% explained by genetic factors. And environmental factors, especially the non-shared environmental factors, were responsible only for 9%. So both disorders have a genetic component, but if you look at these disorders coming together in one patient, that comorbidity is almost completely explained by genetic factors, shared genetic factors. These were the new studies, and now we're moving from a family study to twin studies to genome-wide association studies, and this is probably one of the most famous studies in science in 2018, and there was a shocking experience for psychiatry. They looked at the genetic overlap between psychiatric disorders and neurological disorders. And soon this is the psychiatric disorders, and you see there's a lot of colors here in this correlation table. It means that the genetic overlap between the different psychiatric disorders is actually quite high, whereas in the neurological diseases there is very little genetic overlap. So this is a warning for us. We see all kinds of disorder, but they don't seem, they overlap quite dramatically. So maybe we see more or less one disorder, and our whole classification system is kind of creating this high comorbidity. But they forgot to put in substance use disorder in this analysis, and which happens quite often because addiction is a little bit how do you say, it's a feather in the throat. It hurts. It's not very nice to look at addiction. So a group in the Netherlands said, let's do the same analysis for addiction and the other disorders. And what they find then is that ADHD and the various forms of addiction, they also show high genetic correlations, very high genetic correlations. And recently we did another GWAS study. It was published recently in Drug and Alcohol Dependence. And again, what you see if you look at the genetic relationship between the different psychiatric disorders, we could identify 3 clusters. One cluster that is psychosis, and it includes both schizophrenia and bipolar disorder. One is a cluster of compulsive disorders, which includes anorexia and tic disorder. And there was one cluster that actually includes substance use disorder, ADHD, autism, and depression. So again, you see on the level of the individual genes, you see that there's a clear overlap in the genetics of ADHD and substance use disorder. And recently, there was another, looking at a specific gene. I'm not going into it all too much, but it's one of the glutamatergic genes, and we know that glutamate has an important role in both ADHD and substance use disorder, was identified as significantly contributing to the development of both substance use disorder and ADHD. So this is definitely one of the genes, specific genes, that is responsible for this overlap on a genetic level. And it's not strange that in a study or a review in 2012, a group decided that the relationship between ADHD could be seen as a common genetic network underlying this comorbidity. So emphasizing the role of genetics in this overlap. And this is the picture that I showed you. And I think we could actually quite easily simplify this. If you think that this is driven, these mechanisms are basically driven, where it's about comorbidity, by genetic factors. I'm not saying that the genes eradicate all these pathways, because genetic factors also interact with environmental factors. But many of these environmental factors have no effect if there is not a vulnerability gene. This is just a few examples that we know that is a gene-environment interaction. So I'm not going into this, but to have it a little bit better represented, that this is probably what we see in the comorbidity between ADHD and substance use disorder. It's a relationship that's driven by genetic factors. But of course, and I try to show that by these kind of arrows here, of course, these genes interact with environmental factors and then causing this high comorbidity. And it's an important thing to say that it's the genes that drive this comorbidity, because it also means that in your treatment of the comorbid disorders, you have to take into account the genetic, or more specifically, the neurobiological factors that influence that relationship. So much for the genetics of ADHD and substance use disorder. How is it with the neurobiology of the both disorders? This is sometimes, we didn't steal it. We had a very nice conversation with Gottesman on his paper in the American Journal of Psychiatry in 2003. I think first time they introduced this whole concept of the genotype, the endophenotype, and the phenotype. And they presented that model for schizophrenia. And so we were allowed to use his model for what we do in addiction. And so this is the way we look at addiction. Addiction has a genetic background, and you see here's the lines. The lines represent the chromosomes, and the dots represent the genes on the chromosomes. And if you are born with a certain disposition, genetic disposition, you're likely to be born with a certain kind of brain. And as we know, right from birth, you can see differences between kids. There is crying babies, there's silent babies, there's all kinds of babies, and you're born with a certain specific brain composition. And so some people are born, they're impulsive right away, others are not impulsive, they develop the impulsivity, and this is some of the aspects that we think that are important in addiction. Conflict monitoring and disinhibition, these are aspects of impulsivity, and it's clear that if you're more impulsive, you're more likely to engage in first substance use. Also, you're less likely to control your substance use. Reward deficiency is something like people are born with low density of dopamine receptors in their nucleus accumbens or the ventral striatum, and if you have these low dopamine receptor densities, you're more likely, it's more difficult to experience pleasure, and it's more likely that you only start to experience pleasure if you come in contact with situations where there's a lot of dopamine, and that is, of course, if you start to use drugs. Sometimes people have shown that if you go to a football game, the dopamine releases are like this. If you have a good orgasm, dopamine is like this, but if you have cocaine, dopamine is like this. So these people are not very sensitive to pleasure, but of course, if they get into the most pleasurable activities like drugs, and that is reward deficiency, could be a risk factor for the development of an addiction. And finally, some people are more likely to be easily conditioned than other people. And so these are risk factors. If you're born with a brain that has all this, you're more likely to become an addict later on. It doesn't say that you become, because it's only a risk factor. And of course, there is environmental factors during the time that you grow up. And so they can either make it worse or actually ameliorate this risk to become the phenotype of an alcohol-dependent person. So this is how we think about addiction. And basically what you see in addiction is a combination of hyperactive motivational or reward system. And that makes that people want drugs more. They want drugs all the time. They also, and of course there's no problem with that. If you want it all the time and you don't do it, there's no problem. You just want it. But they also have a deficient cognitive control system. And that combination is very risky, of course. You always want something, but you have no brakes in your mental system. And finally, there is this reward deficiency, and so the drug liking is actually going down. Although they want more drugs, and you know, if you know addicts, you know that in the beginning they enjoyed the drug use very much, but with time it goes down. So drug wanting goes up, the craving goes up, but the drug liking goes down actually. So this is the picture of what you could call the dual process model of addiction. And my statement is this condition, if you think about your ADHD kid that you meet in practice, what does he look like? He looks like hyperactive motivational. He wants something all the time, everything, all the time. And you also know that he cannot stop himself. So he also has deficient cognitive control system. So this is what they share. I would say in that sense, addiction looks like a developmental disorder. It looks like an adolescent brain. This is an adolescent brain. And what is ADHD? It is a low maturing children's brain. Maturation is essential there. And so I think these are all characteristics that you also see in ADHD. So although it's a model of addiction, but you just also see it in ADHD. And we can do delay discounting, and everybody here knows it. If you don't know it, go to the marshmallow test, and you can see it, what it is. It's actually the ability to postpone gratification. Can you stop in order to get something bigger later? And so we know it from alcohol and drug abusers. We know that they can't do it. They want it, and they want it now. And that's what is represented. This is the healthy controls. They say the longer you wait, the higher the line is. So, but when you're not able to do it, you get this line gets steeper. So this is healthy controls. This is substance use disorder patients without antisocial personality disorder, and this is alcoholics with antisocial personality. So they become more and more, they can't stand postponing gratification. So the steeper, the more impulsive. This was a study that we did with healthy controls, ADHD patients and ADHD patients with cocaine dependence. And what you can see is here's again the healthy controls, here's the ADHD, and here's the ADHD with cocaine dependence. So they just have double of that cognitive problem. Also here you see that this is a kind of cognitive impulsivity, also their motor impulsivity is higher. This was a big meta-analysis in children, adolescents, and adults with ADHD. And again, in this study, ADHD patients showed a steeper discounting, so they were more impulsive. So ADHD patients have discounting, and alcohol and drug-dependent patients have it. So they share that. You can also do something like error monitoring. That's a cognitive task in which people have to make a decision, shall I do this or shall I do that? And we know this decision-making, one form of impulsivity, that takes place in the anterior cingulate cortex. And this is a study done in heroin-dependent patients. And it's not so easy to see, but here is this red spot is the anterior cingulate cortex. And what you see is if you give patients a test where they have to make a difficult decision, and of course then the anterior cingulate cortex has to start thinking about what to do, this or that, pros and cons. And you see that in healthy controls the anterior cingulate cortex gets highly activated, whereas in this opiate-dependent patients the anterior cingulate cortex is not activated at all, meaning that if they want to use drugs, they do it. They don't start to debate, maybe this is the pros and this is the cons. We did a similar study, and we compared control smokers and gamblers. And here you see the smokers. If you give them this kind of error monitoring task, you see that there is high activation of the anterior cingulate cortex, indicated here. Look at it, this location. If you do it with smokers, you see this a little bit less. They don't have this decision-making capacity. And here is the pathological gamblers, and they don't have it at all. They come into the casino and they don't think like, shall I gamble now or shall I not do it because I know the problems. They just go for it. They have no possibility to start this balancing procedure in the brain because their brain part is not activated in this situation. So this is a real risk factor. And now let's look at the same task in adult ADHD patients. You see, this is normal controls. They activate their anterior cingulate cortex, and here is the adult ADHD patients, no activation of their anterior cingulate cortex. So again, addicts and ADHD patients show the same neurobiology in terms of their decision-making problems. And that, of course, made people think like, what are the factors that make certain patients with ADHD develop an addiction? And so this group in the Netherlands, they start to look at, can we predict which patients with ADHD do develop an addiction? Maybe this is because of their cognitive problems. And they had a big set of cognitive tasks, and none of these tasks, these are the results, so you can't follow that, but I can tell you nothing. They didn't find any relationship between certain cognitive tasks and the risk of ADHD patients becoming an addict. And so they conclude that the cold neurocognitive function, so it's all the impulsivity, executive function, and so forth, they don't predict the development of substance use disorder. So they said it must be something else. It must be the warm cognitive functions. And the warm cognitive functions is functions that are related to reward processing. So an important finding, but also a disappointing finding, of course. Now, recently, they have also started studies not with using cognitive tasks to measure impulsivity, but have self-rated impulsivity. And self-related impulsivity is not related to measured impulsivity with cognitive tasks. And if they do that, and this is a cross-sectional study, they see a clear relationship with certain aspects of ADHD and the development of alcohol dependence. And the factors that were important was actually what they called negative and positive urgency, which is a tendency to act out impulsively in response to positive or negative emotions. So it seems that there is a cold function, but then the self-reported one that is related to. And this was actually confirmed in a prospective study. And they showed that, again, that negative urgency and positive urgency had a clear mediating role between ADHD and substance use disorders. Reward deficiency, I talked about it. That's a real problem in patients with ADHD. Here you see healthy controls, and here you see people with different addiction, cocaine addiction, methamphetamine addiction, and alcohol addiction. And this is 3 months after they stopped using these drugs. And the more red you see, the more dopamine receptors are there. And you see in all these patients with an addiction, there are much less dopamine receptors. And so this might be this indication of reward deficiency, this idea of anhedonia. And of course, this could also be a consequence of the drug use. And we will never know with human studies, but animal studies have shown clearly that this reward deficiency is probably both a cause and a consequence of drug addiction and drug use. Now, how is that with ADHD? And I don't have the beautiful pictures, but I have a wonderful study, of course, by my dear Nora Volkov. And she showed actually very similar results for patients with ADHD. In a PET study comparing medication-naive ADHD patients with healthy controls, they showed significantly lower dopamine transporter and dopamine binding in regions of the dopamine reward pathway, so an indication of reward deficiency also in ADHD patients. So there were many more studies on the comparison between ADHD and substance use disorder in studies on neuroimaging. And this is what a review from 2070 actually said. You see, ADHD patients are actually, as I told you before, they are defined by reduced deficient cognitive control and increased reward processing. So this is a normal ADHD patient's even lower impulsivity and higher hyperactive motivational or reward center. And based on the studies that I showed before, you could say probably the ones that develop addiction, the ADHD people develop addiction, maybe they don't have so many extra problems in impulsivity, but they have extra problems in the reward processing. But that was before we had these data on positive and negative urgency in the self-report on impulsivity. And so now I think basically probably this is the better model for those ADHD patients that develop addiction. So this is what we know now about this relationship. Now, of course, this is all nice. You have a model and you can do something nice on that. But can we also use it in the prevention of ADHD and of substance use disorder in patients with ADHD? And so that would be wonderful if you treat the ADHD, maybe you can break this causal pathway. So that would be nice, isn't it? That the 50% of patients with ADHD that develop an addiction, maybe it can be reduced to 20% or maybe even lower. And this was one of the first studies that gave us a clue to that. And it was a study, again, I showed you that's a follow-up study. It's not a randomized controlled trial. There will never be a randomized controlled trial. So what I'm going to show you is that is what there is, and you have to act on that. Because there's not going to be a randomized controlled trial where children with ADHD at the age of 8 get a stimulant and they're followed till age 25 and see what happens. There's not such a randomized controlled trial. So we have to do it with naturalistic studies for making our own conclusion and starting to think about treatment. So you see that with this study, 50% developed substance use disorder. Now the question, 50% also doesn't. Can we predict the ones that developed an addiction? And they looked at 30 factors, and there was only one factor that was significantly predicting the development of a substance use disorder. And that was the time that people started to use their methylphenidate. And the earlier they started to use their methylphenidate, the smaller was the risk that they developed an addiction. So, unlike what many parents might think, that if your patient is being treated with a stimulant, he will be more likely to develop addiction. This doesn't say that they were all treated with the methylphenidate, but the earlier you started, the better was the outcome. Since then, there have been many studies, and this is, forgive me by being so critical, there is a lot of meta-analysis, and some meta-analyses are good and some meta-analyses are just rubbish. This is one of these meta-analyses. They did a wonderful job in doing the analysis, and this was the outcome. And what you see here is that there were studies that showed that patients with ADHD that got a stimulant had a higher risk of becoming addicted, and there were studies that had a lower risk. And so it's all over the place. Bigger risk, smaller risk, overall nothing. So to say, it has no effect. I think that's stupid. You have to analyze why some studies find it and other studies don't find it. So I don't know what you can use. It's very likely that patients who get a stimulant are the more severe patients. And even if they have the same risk of becoming addicted, maybe there was protection of the stimulant treatment. So this is quite useless. It's being cited all the time, but I think it's... So I look for studies that were published ever since, and this is one of the studies, again, from the Nijmegen group from the Netherlands, but also working together with Steve Faroni and from the US. And they looked at the development of addiction in children with ADHD or healthy controls between age 12 and age 17, 18. And what they saw very clearly is the healthy controls, they're not very likely to develop a substance use disorder. At age 70, it was about 8–9%. Patients with ADHD without a stimulant treatment, they developed an addiction in about 22%. Whereas the ones that use the stimulant, you see, they're very close to the healthy controls. So they normalize the risk of becoming addicted, at least at age 17, 18. So it's a very interesting finding, and moreover, they found the earlier they started with the stimulant treatment, the better was the protective effect of stimulants. So a very important study, but it's observational. This was another study from the same group with another population, and they even did a little bit better. They were followed ADHD patients in healthy controls from age 12 to age 16. And they looked at how they used their stimulants. So they identified a group that used no stimulants, a group that started late with using stimulants. They started using stimulants only at the age of 11, and they had only moderate dosages of methylphenidate. There was an early group that started early, 8 years, when they started to use the methylphenidate for the first time, and they used moderate doses, and they had a group that started early, and they used intensive doses, on average 53 milligrams of methylphenidate. And so they start to look how the addiction developed in these different groups. It looks a little difficult, but you see it quite simply. You see the same picture again. Between ages of 10 and 18, 20 years, you see if these ADHD patients use no stimulants, they have a high risk of developing addiction, any substance use disorder. If they use low levels, medium levels, or they start late with the stimulant treatment, they have lower levels of addiction, but it's the best results when you start treatment early with adequate dosage of stimulants. Then the risk of developing addiction is the lowest. And the same is actually true for nicotine dependence. Although the main important is that you start the treatment with methylphenidate at a young age, which means age around 7 on average. There are also a lot of indications from registry studies, and I'm not going to go into detail. This is a registration study from Sweden. They're known for that with almost 30,000 patients in the registers. And what they showed is that if you look at these registers and you look at patients that developed an addiction, and you look at the ones that had had ADHD in their history, if they started to use stimulants before age 15, it's not the best indicator, it should be much earlier, but if you started to use stimulants before age 18 in this registration study, the risk of becoming addicted went down with about 30%. And the same thing was found in a web-based survey, was published, I think, in 2016. Again, there is a protective effect of medically prescribed stimulants. And the earlier you do that, again, the better are the effects, the protective effects. So I think it comes with a strong recommendation. If you have patients with ADHD, of course, we start treatment with cognitive behavior therapy, with environmental measures, with training program, coaching programs. But if the complaints go on, start treating with stimulants, and preferably at an early age and adequate dosages, because it might actually give a preventive effect, probably not only for the prevention of addiction, I'll come to that, but also all kinds of other things like accidents, like criminality. So I think an important message to all people that treat patients with ADHD. And the question is what it does. What does the treatment with stimulant actually do? This is an interesting study, was published in the American Journal of Psychiatry. It looked actually at different studies of ADHD patients treated or not treated with stimulants. And this was the different age of the different study samples. And you see the older sample, and this is the size of the ventral striatum, and what you see actually is the older they get, this is zero is that patients with ADHD has the same volume of the striatum as healthy controls, and you see samples of young ADHD patients, they have a much smaller volume of the striatum. And only at age 40, they seem to reach a normal size of that part of the brain. This is the more interesting part of that study. Here you see the different samples, and they show which percentage of the sample of these ADHD patients used a stimulant. And what you see then, if you have samples with very low use of stimulants, they say they have a much smaller volume of the striatum, and only in the samples that where you have high use of stimulants, you see they have a normal, 0, they have a normal volume of the basal ganglia of the striatum. So it seems that stimulant is actually providing growth of certain brain areas, maturation of the brain. That is what stimulants do. And this was a recent study looking at the similar things, looking at the different parts of the brain. Here it's the gray matter volume of the prefrontal cortex. Here is the gray matter volume of the occipital visual cortex. And what you see is this is the normal control, the healthy control, the typically developed group. Here you see the medicated ADHD group, and here you see the never medicated group. And you see the medicated group has the same median as the normal controls, and you see it's only the never medicated, they have a smaller prefrontal cortex, gray matter volume in the prefrontal cortex, and the same is true for the visual cortex. So again, showing that medication seems to normalize not only brain function but also brain structure. And so this is a review showing actually that most studies suggest that brain structure and brain function improve in the course and following stimulant treatment. Now, of course, there's questions about safety of long-term medication of patients with ADHD. This is a wonderful review looking at risk factors in the long-term treatment of patients, young patients and adults. And their conclusion is that the treatment of children and adolescents with methylphenidate or atomoxetine is associated with increased heart frequency and diastolic blood pressure, but not with increased risk for cardiovascular problems. So it just means that you have to monitoring the medication of your patients very well. So as I told you, ADHD is not only protected, if you give stimulants, it doesn't only protect the development of substance use disorder, it also seems that it protects people from having accidents, criminal behavior, depression, suicidality, and seizures. And these are not only short-term effects, it's also indication that they're long-term effects. So this is to prevent addiction in ADHD patients. What about people who still develop ADHD and addiction? Can we treat these patients? There is not so much known, and what is known is not very positive, at least in the beginning. This is a recent study, and it just started very much at the beginning, and they just had a retrospective cohort study, and they started to see what happens in terms of treatment retention if your patients with ADHD and an addiction. What is about treatment retention? It showed very clearly that treatment retention in those treated with ADHD medication was much better than those that weren't treated with ADHD medication. Now, it's very nice that you stay in treatment, but does it help? Because it's very nice that we stay in treatment, but if there's no improvement, either in the ADHD or the substance use disorder, then you're in trouble. And this is a review of all the studies that were done in patients with ADHD and an addiction. And the conclusion that I wrote down is actually that the treatment with stimulants and other medications has very little or no effect on ADHD symptoms in these patients, and no effect on substance use. So I regard stimulants as one of the most effective treatments in psychiatry. Effect sizes of numbers needed to treat like 3, 4, whereas in the rest of medicine and the rest of psychiatry it's 5 to 10. So, but not in this population. In the population with ADHD and an addiction, stimulants don't seem to have a great effect on ADHD symptoms. So the question is why, of course, but it doesn't seem to have a great effect. This is the overview of all the studies we've done, and what you may see is that there's a lot of red here, all no effect, no effect. And so the question is why, and so we did a study some years ago, it's about 8 years ago now that we did it, and we looked at patients with ADHD and patients with ADHD and cocaine dependence, and we gave them a standard dose of methylphenidate. We looked at blood levels of methylphenidate in these patients, and they were the same in both patients, and then we started to look at occupation of the dopamine transporter in the brain, and it turns out that the same doses of methylphenidate has much lower occupancy of the dopamine transporter in patients with ADHD and a comorbid cocaine dependence. So it's not strange that standard doses of methylphenidate don't work in patients with a double diagnosis, because it seems that the occupation of the dopamine transporter, which is the transporter that needs to be occupied by methylphenidate, is much lower. So the obvious conclusion might be that you have to give higher doses in these patients, higher doses of methylphenidate. And so there are 2 studies only now that try to do that strategy. And one is a Swedish study, and they used higher dosages of methylphenidate in patients with ADHD, adult patients with ADHD and amphetamine dependence. They went up to doses of methylphenidate to 180 milligrams, which is quite high. And there's another study from the United States, and they used amphetamine, mixed amphetamine salts, which means slow-release dexamphetamine, in doses what they call robust. They don't say high. They don't like to say that they use high dose. They say robust doses. But these are high doses, 60 to 80 milligrams of dexamphetamine per day. And this is the findings of the Swedish studies. They showed very clearly that in terms of the ADHD, the number of responders that you had from the placebo plus cognitive behavior versus the methylphenidate slow release with cognitive behavior therapy, it's a big difference in response rates, you see. And so it leads to a number needed to treat of 2. So finally you see an effect. We thought there was no effect on ADHD in these patients, but if you dose higher, you suddenly see the effect that you would expect. So what did this study do on drug use? This is their findings on the amphetamine use. So here is the proportion of negative urines, and you see the proportion of negative urines in the methylphenidate is much higher than the negative urine in the placebo group. Now you may say, okay, that's because you just replaced amphetamine by another amphetamine, by methylphenidate. You're just doing substitution treatment. So that is what you see. I wouldn't mind if that happens, if that is the effect. But there was also another finding. They saw also reductions in all kinds of other use of substances. So reduced in cannabis use, benzodiazepine, and opioids. So maybe it's not only amphetamine substitution, maybe something more goes on there. So this is a very promising finding. And there's another study from the United States using these high doses, or robust doses of dexamphetamine. Study was published in JAMA Psychiatry. This looks very difficult to read. So with her permission of Frances Levin, I took this slide. And if you see what happens here, this is, let's start with the reduction in ADHD symptoms. You see that the reduction of at least 30% in ADHD symptoms compared to placebo, the reduction is much higher in the ones that use the mixed amphetamine salts. But you see the best effects here is with the 60 milligrams. Whereas if you look in the reduction of cocaine use and percent cocaine abstinence in the last 3 weeks of the treatment, there you see the higher doses is doing better than the moderate dose. So what it means probably is that you have to start to titrate with your patient what's the best doses for your patients to both have reductions in the ADHD symptoms and the use of, for example, cocaine. This is a Swedish registration study, and it just shows again, and this is naturalistic, and it shows again that if you look at the treatment retention, you see the higher doses are much better in treatment retention than the low dosage. At day 800, treatment retention was 48% in the high doses, 108 milligrams of methylphenidate, compared to the 33% retention in the low dose of methylphenidate. A difference of about 15%, which is substantial. An important issue is, of course, if you start with high doses of methylphenidate, will these patients just go up again and again and again and until they're completely addicted to your medically prescribed methylphenidate? And this is a study from, again, Sweden, using their wonderful registers. And they indeed say that these are patients with ADHD patients without a substance use disorder. And you see they started with lower doses of methylphenidate in their treatment. Here are the patients with ADHD and an addiction. And they see they start with higher doses. And initially it seems that the doses is not high enough. And so they move up higher dosages in the course of their treatment. It seems that their doctors increase the doses because they don't see enough effect. But then you see actually a plateau, and they don't move up to real addicted levels of methylphenidate use. So it seems that it's quite safe. But again, if you start to use high dosages of stimulants in ADHD patients with an addiction, I think you have to be very careful that there is no new addiction being induced or that there is diversion of the medication. So monitoring, not giving medications for a long period of time, So you have to be careful with this kind of treatment. But if you're daring to do it, then I would say if you start to treat these patients with ADHD and substance use disorder, I don't say that you have to go to high doses always, but as a doctor you have to be willing to go up if the development of the disorder and the lack of treatment effect deserves higher doses. So you have to have this idea that you might end up with higher dosages. Maybe because there was also child and adolescent, there was one study in all these studies that was a study of Riggs in 2011, doing this study in patients, young patients, adolescent patients with ADHD and basically cannabis use disorder. They had a very interesting finding. Overall, there was no effect. But they had a very interesting finding, and that was in an additional paper they wrote it down. And what they found is that maybe there was no overall effect in patients with ADHD and an addiction. But in the subgroup that had ADHD, addiction, and a conduct disorder, so a triple cripple patient, they had a wonderful effect of methylphenidate. So again, so it seems that the comorbid presence of a conduct disorder is not necessarily a contraindication to prescribe methylphenidate. Maybe in some of these patients you might even have more effect. Of course, there's also more risks of addiction if you have a comorbid conduct disorder. So here it's not so easy what you do, so you have to be it's not science. This is really the practice of psychiatry that you have to do with these very complex patients. And finally, is there any form of psychotherapy that you can do with these comorbid patients? Unfortunately, there is very little. There's very little studies that try to do that, and this is the only study that I know of. It's a study that we performed in Amsterdam, and we compared CBT for substance use disorder with integrated CBT, so with extra sessions for ADHD, so it's a combined integrated treatment. And what we saw of that is that in terms of the effect on the substance use, it was very similar, but in terms of reduction of ADHD symptoms, it was much more effective. So it's not only medication, there's definitely also something to be achieved with an integrated form of CBT, but I have to say there's much less data on it, and it should be explored much further. So if you want to read about all this, and I think here I'm going to stop, so I'm not going to do all the things about gaming and gambling disorder. You can talk to me afterwards, and you can have my slides if you want them, just write me a mail. We wrote all these things down in two consensus papers. The first consensus paper was for adult patients with ADHD and substance use disorder. It was published in 2018 in European Addiction Research. And we also wrote one for adolescents. And first we did a systematic review, and that was published very recently in Journal of Clinical Medicine. And then we also wrote we actually did a consensus statement. We had 35 statements on adults with ADHD and substance use disorder, and we asked all these people on the slide in a consensus procedure, in a Delphi procedure, whether they agreed with some statements or not, and so that resulted in about 35 diagnosis and treatment recommendations, and so it was just recently published in European Addiction Research. So this is my conclusions for this part of the talk, and I will stop there. ADHD and substance use disorder frequently co-occur, and 10 to 25% of treatment-seeking addicts, they have an adult ADHD. Childhood ADHD is a predictor of substance use disorder, independent also of oppositional defiant disorder and conduct disorder. Early stimulant treatment of ADHD can prevent and will prevent the development of substance use disorders. I think that's probably the most important statement that I want to make here. On the condition that you start early and you use adequate dosages, that seems to be the indication of the data. This coming genetic network seems to underlie the comorbidity of ADHD and substance use disorder. And that also may explain why the neurobiology of ADHD and substance use is very similar, with high reward sensitivity and deficient cognitive control, but also with difference in self-reported impulsivity and reward processing. And they predict the development of substance use disorder. ADHD patients with and without substance use need different treatments. They need higher dosages of stimulants, and you have to be careful with that, but you have to consider doing it. And they might benefit from integrated cognitive behavior therapy. And I think that's where I should stop, and I don't do this because I think it's almost time. So thank you very much for your attention.
Okay, thank you very much, Professor. It's been an excellent speech, a textbook presentation, really. And thank you for that. So we have some time for a couple of questions from the audience. Yes, Professor Greenshaw. Mic is coming.
I guess the mic is for everybody. So, Wim, that was a fantastic lecture. Really, lots of new information for me. One of the things that I do is work with machine learning and predictive analytics. So people have started to apply machine learning to prediction of the potential for substance use disorders in adolescents, but I haven't seen it applied in this area. So has anybody started to do that? Because with such a complex data set, it seems like a perfect place to play, especially if you want to have the possibility of getting a better decision-making ability for an individual patient coming into your practice.
Fully agree with you that it's a very interesting new tool. Sometimes it depends on who does it and what the data is that you have. Machine learning gives you very interesting information, but sometimes it's not so easy to interpret in clinical sense, depending a little bit on your variables. I've seen a lot of machine learning with fMRI data, and I think I never learned anything as a clinician. But as soon as you start to use it with clinical data, you might definitely learn more than we do now with our standard procedures like doing logistic regressions and looking at individual contributions of factors. So far the studies are not there. In terms of the treatment, it's also limited. If you see the high dose studies, there's only actually 2 now. So I based this talk and my recommendations on 2 good randomized controlled trials, but they were short-lived, these randomized controlled trials. It's much more interesting to see and these were for the treatment. If you look for the prevention of addiction in ADHD patients, we have a lot of observational studies, and there will never be a randomized controlled trial. And it's very unfortunately for us clinicians to have to act on the data that we have, and that is naturalistic data. But still we have to do something with our patients. So I make a conclusion based on the data that I see, and I do something. But I fully agree, we should use machine learning, definitely. It's in our hands. It's not very difficult. There's software available that is not that complex anymore, so it's absolutely right.
Yeah, that was brilliant, wonderful slide and very eloquent, beautiful. I learned a lot. But just maybe one or 2 questions, if I may. Full circle for me would be that there would be a study where you convincingly showed that this reward deficiency was going to be altered in a maturing brain. And I was dying to see a new study that may have been out, or maybe I missed it, that showed that the anterior cingulate gyrus was going to be active in this reward task. Now, is there any evidence that the ones that are treated that respond positively, or in which the brain matures in a positive way without any of the symptoms of ADHD or substance use disorder, they have an ACC that does have that inhibitory control?
There definitely are some studies, there are clinical studies that show that with time, with these patients, even if they still meet criteria of ADHD at an adult age, that their impulsivity goes down, their inattention stays very long. So impulsivity actually seems to mature out in many patients, and there is some fMRI studies showing that in these tasks, like the stop signal task and these kind of tasks, which is kind of really motor impulsivity, there they improve. So if patients improve, their cognitive functions also go up, and you see it also in fMRI studies. Now, your question whether in these patients we have these data, we don't have them. I think I basically summarized what we have so far. So,
could it be hypothetically that their dopaminergic reward circuitry is developing maybe at a later stage? That it takes them more time to develop it to its full integrity?
I think that definitely is the fantasy. I'm not a child and adolescent psychiatrist, but that's definitely the idea that we have about ADHD, that it's a brain maturation disorder, and that it's with time. That's probably the reason why some of these children with ADHD, they grow out of their ADHD a little late, like their prefrontal cortex is not ready at 20, but maybe at 25. And you saw these ages of this population in this one study. You see, with age, they seem to look more like a normal brain, a normal maturating brain. And it seems that and that's the other part of the thing, that with providing stimulants, you do actually give a boost to this maturation process. So it's definitely what I think the fantasy, it's not a fantasy, there is some data, but it's not strong, that with the stimulant treatment, and maybe also with the atomoxetine treatment, you actually do help the brain maturate faster than it would have done otherwise. So,
if I may, another question. Is that the message that then, if I had young kids with these things, now you're convincingly showed, oh, you need to start early and start high. Is that the message that you would give to the parent to motivate this young kid? Like, we need to titrate up a little bit, because as a parent, I would be relatively or somewhat reluctant to treat my child with these compounds at a young age.
Yeah.
To prevent actually a disorder that is only prevalent in a relatively minority of the cases. Turning into
I wouldn't say minority. If
No.
you want to prevent addiction, and not only addiction, I showed a picture where stimulant treatment always prevents criminality, also prevents accidents, and there are some indications from Swedish registry studies that it also prevents early death. So some people say ADHD is not, it's a social thing, it's not a disease, it's just our teachers are just not patient enough with our kids anymore. It's just a social thing. Okay, it's a social thing, but kids die young from it. You don't want that. Kids develop addiction in rates that you don't want. And of course, it's not always easy to make a distinction between a normal adolescent and people with ADHD. So you have to go back. Of course, we do that. That you never make a diagnosis of adult ADHD in an adolescent just by saying, oh, you have these symptoms, because they look sometimes like just an extreme adolescent. But if you go back in history and you see the failures in school and you see the parents, so you have to do a proper diagnosis. Proper diagnosis need treatment, and as I see it, of course, you have to do something with the parents, like coaching, cognitive behavior therapy, but it doesn't work always. And try to do that first, and if you're not successful, don't hesitate with stimulant medication. It's safe, it's effective, and it also prevents later problems. And of course, you do it in close collaboration, but I don't have to say that. You do it in close collaboration with the kids and the parents. They take drug holidays. Of course they do that. They want to, in weekends, they don't want to use the medication, but in school, okay, they're happy to do it. So we have to find a way to get these kids and the parents in stimulant treatment or in atomoxetine treatment as good and as continuous and as long as possible. And you lose sometimes. Sometimes they do it for half a year and they stop. And so you invite them back. You say, okay, you stop. We stop together. And come back. We don't leave you alone, because you have follows these kids. If you meet them at age 6, you have to follow them till age 25. Then you see what happens. And of course, it doesn't always work like that.
Great. Last question. Yes.
Thank you for your excellent presentation and slides. Methylphenidate is not effective some children and adolescents with ODD and CD. What is our options, and what do you think about the risperidone or some antipsychotic treatment in this area?
Yeah, very good question. In general, I think that there is not very strong evidence for the effectiveness of methylphenidate in the treatment of conduct disorder, although there was just recently a study by Litt and others from Amsterdam. They showed in a randomized study only giving 2 doses of methylphenidate in disruptive behavior disorder kids. They showed a clear normalization of functional MRI data in these conduct disorder ODD kids. So I think there is some indication that methylphenidate might do something there. And then there is this study from Pamela Ricks, which shows that there is something, but the evidence is very thin. And of course, you can go to antipsychotics. We're not happy with that. Sometimes you have to, and that's also where we are. Sometimes the aggression is too big, or the parents cannot handle, and so you go to hopefully low doses of antipsychotics. It's not a charming treatment because it doesn't resolve the issue. There's no indication that it really stimulates the maturation process. It is a dampening of the behavior. So I would be very happy if there's more studies coming with methylphenidate in this population, see whether we can somewhere find the right dose, and maybe even, and it's very difficult, maybe higher doses there would do the job. But I'm aware that if you start to use higher doses in these kids, the risk for abuse, the risk for diversion becomes even bigger. So again, you're in a situation that clinicians are always, you have to do what is not being proven, and you have to work around it. But I would be much more happy with that than with providing them with antipsychotics.
Okay, excellent. I think we should leave it here. Professor Van den Brink, thank you very much again for this excellent speech.